So this is the latest instalment in the Interacoustics Academy webinar series, and the title is Masking in the Auditory Brainstem Response. Now, in case you're not familiar with who I am, my name's Mike Maslin. I'm an audiologist and a clinical trainer with the Interacoustics Academy, and I was trained in the UK, and so I've constructed today's talk with a very UK-centric perspective when it comes to the specific clinical procedures for masking. Now, I'm aware that if you're viewing from different regions around the world, then your specific procedures, clinical procedures, may vary a little bit. However, so that's not to say that that one's right and then the other's wrong or anything like that. There's natural variation, but the underlying principles that we'll talk about today, they apply wherever you may be based. So what we're going to do, I've got quite a long introduction, which I think is important to establish, or at least to remind ourselves of some of the mechanisms, physiological mechanisms of cross-hearing. In other words, the phenomenon that leads to the need for masking. So with that basis established, I'll then just go on to talk about masking in the auditory brainstem response, both from a theoretical perspective and with use of a case study example. And many of you may also be interested not just in the auditory brainstem response, but also other types of evoked potential, such as the ASSR, the auditory steady state response, and the cortical evoked potential as well. So whilst it's not the focus of today's talk, I'll just in closing mention some differences in procedures for the ABR and those other types, the ASSR and the corticals. Now, in this first slide here, I would like to just establish the phenomenon of transcranial transmission. Now, as we can see from the schematic, the bones of the skull, and in particular, I'm interested in the cranium, the part of the skull that actually holds the brain. And in the adult skull, as we're shown in this schematic here, the various bones of the cranium, such as you can see from this top-down view here, are knitted and fused together along these suture lines here. And so what that means is that as the skull vibrates, then those vibrations can be passed through the different plates of the skull, and they reach all the different parts of the cranium. Now, this is very important because, of course, the ears, the cochlea, are encased within the temporal bones of the skull, and so those vibrations will pass through the cranium and reach both cochlea. Now, from the point of view of masking, the relevance of this will become clear in just a moment, but I would like to just explain how this has been known for quite a long time in the literature, and a very important study can be we can use to illustrate this point. So I'll mention this study. It's the von Békésy famous cancellation experiment. Georg von Békésy, sometimes described as the father of audiology. And in this study, what he did was he took a group of adults and he placed a bone vibrator on the midline on top of the head, such like this, and played a sound signal, you could say a pure tone, into the bone vibrator, and then the individuals were able to hear that sound. And then what he did was, in terms of the cancellation, he simultaneously presented via the normal air conduction route the same sound down both ears, but just varied both the amplitude and the phase of that sound, just tweaked it here and there a little bit, until such time as the sound from the bone vibrator was cancelled. And he knew this because it was suddenly no longer audible to the participant. So this interesting phenomenon just tells us two things really. First of all, we know that bone conducted sound can be perceived by humans, So the bone vibrations passing through the skull that Georg von Békésy introduced were detected and heard. But then secondly, when the air-conducted sounds reached the ear, then because the sound was phase cancelled, then we know that that tells us that the particular type of vibration on the basilar membrane inside each ear is exactly the same whether or not it was heard by air conduction or bone conduction. So the type of sound vibrations, once they reach the ear, are fundamentally the same type irrespective of how they got to the ear. And we know that because otherwise the sound wouldn't have been cancelled in that way. So that's a little bit about bone conduction. The main take-home message from our point of view, of course, though, is that sound can be perceived by bone conduction. Now I'd just like to mention a new term, a new phenomenon. That's the one of interaural attenuation. Now, as these bone vibrations pass through the plates of the skull, to some extent their energy will be dissipated, and the vibrations will fade out. And this happens because the energy of the vibrations encounters the resistance of the bones and then the other material, the soft tissue of the head, and that dissipates the energy. And if the energy if the energy from vibrations on one side of the head is dissipated before those vibrations reach the other side of the head, then the sound vibrations haven't overcome the interaural attenuation. Now, on the other hand, if the sound vibrations are high enough, then they might reach all the way over to the other side of the head and be detected by by both ears before the interaural attenuation has dissipated the sound. And I've just produced a few slides to try and illustrate this phenomenon here. So, for instance, in this example, we can see the bone vibrator pressed against one side of the head, and for a very, very low level of sound stimuli, those vibrations are propagating through, and they're high enough to be detected by the cochlea on the side of the head that's on the same side as the bone conductor, but the vibrations very quickly at that point dissipate away, and so the opposite cochlea on the contralateral side over here, that wouldn't hear the sound in this example. So that would of course be a very, very low level sound. But if we turn the sound level up just a little bit, then we might be able to get those sound vibrations to pass a bit further through the plates of the cranium before the energy was completely dissipated. Now here again, we haven't completely overcome the interaural attenuation, and so again the cochlea on the contralateral side still wouldn't be able to pick up this sound either. But an increase again, and it might be that the sound vibrations pass all the way over, and in this case the vibrations are said to exceed the interaural attenuation. Now I've shown this example with the bone vibrator, and since sounds crossing from one side of the head to the other primarily do that via the vibrations of the skull, as I've mentioned, then the sound level, you might not expect the sound level to be very high before the interaural attenuation is exceeded. Now, something similar also happens with air conducted sound, but the interaural attenuation is naturally higher. So what I'm showing here is sounds that are being presented down the normal air conduction route, and in this case it's an insert headphone, and to the ipsilateral cochlea we would, the sounds would pass down the ear canal through the middle ear bones and then into the inner ear. But the insert headphone is in contact with the soft tissue and the skull surrounding it via the sponge of the insert, and so with a high enough sound intensity, then the bones of the skull can still be set into vibration, and those vibrations can pass over in the same way as we showed before to the opposite cochlea, the contralateral cochlea. Similarly, if we had, for example, a supraaural headphone, the same thing could happen in that sounds would pass down the normal air conduction route, but at some point, with the sound intensity high enough, the contact of the transducer to the side of the head would be expected to set the bones of the skull in motion and send sound vibrations across also. And naturally, the intraoral attenuation of a supraaural headphone is slightly lower than that of an insert headphone, and that's because the surface area in contact with the head is slightly higher with a supraaural headphone than it is with an insert. So that's in a nutshell the concept of interaural attenuation. And so when we present the sounds of a high enough amplitude, then the sound waves may exceed the interaural attenuation and reach the other ear. Now this is really important from the point of view of pure tone audiometry, because pure tone audiometry relies upon being an ear-specific test, both to accurately diagnose the extent and the configuration of a loss, whether it's air bone gap or completely sensory neural or completely conductive, and also of course which ear is worse and to what extent. So with sounds potentially exceeding the interaural attenuation in some cases, such as where there's a large asymmetry between the two sides, or a unilateral or a bilateral conductive loss, then this ear specificity may be lost, and that could lead to the wrong diagnoses and then the wrong management. So in order to restore ear specificity to the pure tone audiogram, now I'm just concentrating in this introduction on pure tone audiometry, but of course we'll go on to talk about the auditory brainstem response in due course. But to restore ear specificity, masking is required. And so what I'm displaying in this schematic, again, just going back to the bone conducted sound, what we'd have in terms of when we know we've exceeded the interaural attenuation value, then we'd present masking to the non-test ear. Now it's important that you appreciate from this slide that the presentation of masking doesn't prevent the sounds from crossing over. You can see that the sound waves are still crossing over in the same way as they did before, but the masking now prevents the non-test ear, the contralateral ear, from detecting those sounds that are crossed over. So it temporarily raises the threshold in the non-test ear. And we would do the same thing, slightly different procedures of course, but in principle the same thing, whether or not it was bone conducted or air conducted sound, such as here with the supraaural, or here with the insert phone. So because the values of interaural attenuation differ slightly between air conduction and bone conduction, then our decision to invoke masking is slightly different, and also because of the differences in the transducer that I mentioned, for example between inserts and supraaural, the different interaural attenuation values, then the masking rules will also differ in the AC method, depending on the type of transducer that you're using. But irrespective of those details, when you decide to invoke masking, if there's a risk of cross-hearing occurring because the sounds exceeded the interaural attenuation, if there's a risk of cross-hearing and you decide to invoke masking, then there are really two possible outcomes. Either, despite the risk of masking, actually the sound wasn't being cross-heard, and the threshold in the test ear was indeed a true threshold. In this case, despite the addition of masking, nothing will change in the values of threshold that you've measured. Or on the other hand, in fact, the sound was being cross-heard, and what you were measuring when you were testing one ear was actually the threshold from the other ear, and in that case it was a shadow of the better ear. And so what I'm going to just show with this schematic here is what can happen when sounds are detected in the non-test ear, and then how the masking helps to prevent that from happening. So what we're showing in the non-test ear here is a schematic of the basilar membrane with the hair cells of course lined up, and they're lined up in a tonotopic fashion. And this red hatched area here shows the envelope, the excitation pattern on the basilar membrane of the non-test ear when a sound is actually cross-heard. So this is the sound that's crossed over from the other side and is picked up in the non-test ear. And then so when we invoke masking, what we do is we present a narrowband noise which is specifically designed with just the correct bandwidth for the type of pure tone signal that we're interested in, so that it completely covers, in terms of its amplitude and its bandwidth, the excitation pattern from any cross-heard sound. And in pure tone audiometry, that's typically a 1/3 octave wide narrowband noise that's just centered on the pure tone frequency that we're testing at that time. And so it covers both the characteristic frequency, the area of maximum vibration on the basilar membrane here, but also any areas where there's a degree of off-frequency listening, just a little bit lower and a little bit higher in frequency to that characteristic frequency. So that's the narrowband noise masker. Okay, so a question is, and this becomes relevant when we do go on to talk about the ABR in masking, but a question that you might have in terms of the masking with pure tone audiometry by way of introduction is, okay, so when is masking required? When is there a risk of cross masking, of cross hearing? Sorry. And as we mentioned, with bone conduction sounds, the risk is very high almost all the time, and the intraoral attenuation for bone conduction could be as low as 0. Now, pragmatically, we don't take 0. We might take 10 dB intraoral asymmetry, for instance, as the signal to require masking, and that's just a pragmatic approach. But in AC, the intraoral attenuation is much higher. For the, at least in the UK, the decision to invoke masking would be when there's a difference between the left and right ears of 40 dB when it's a supraoral headphone, and 55 dB when it's an insert. So in other words, the values of intraoral attenuation are thought to be at least 40 dB and at least 55 dB for those two types of transducer. And so a question is, where do these values come from? And these have been, again, known to the literature for quite a number of years, and a number of different studies have aimed to look at this. And one of them is a relatively recent study by Munro and Agnew in 1999, and I'll just briefly use that one to illustrate where these two values come from. And this study is brilliant and ingenious in its simplicity, because what they did was they took these authors 18 adults who had complete unilateral deafness, as you can see from the schematic here, complete deafness on one side. These were adults who had undergone translabyrinthine surgery for the removal of an acoustic neuroma. Now, acoustic neuroma, in case you're not aware, is a benign, slow-growing tumour that affects the 8th cranial nerve. And when this tumour maybe reaches a certain size, one management option is to remove this tumour via microsurgery. And there are different surgical approaches to access this tumour, one of which is known as the translabyrinthine approach. And in this approach, what the surgeon does is they perform a mastoidectomy, and then they perform a labyrinthectomy. They remove the cochlea and then the other components of the inner ear in the vestibule, and then they access the internal auditory canal from the side to give them a very clear and wide angle to remove the tumour from there. Now, so in the process of this surgery, the patient obviously undergoes profound deafness on the surgical side, because they have their inner ear removed, and the auditory nerve itself is sectioned as well. Now, it may be that the tumour in these types of patients has already reached a certain size that isn't really a major consideration for the patient, but they're left with complete profound deafness on that side. And this is very, very useful from the point of view of research studies like this one, because you can, of course, guarantee the severity and the type of deafness. And so what they did in this study, they took 18 of these such people, and in the non-surgery side, in the opposite side over here in the schematic, they had either normal or near normal hearing. And what the authors simply did was they measured the pure tone thresholds to two types of transducer, the TDH 39 headphones and then the insert ER3A insert headphones. And so they measured the pure tone thresholds in the good side, and then they measured the pure tone thresholds in the dead side. And of course they knew that the sounds when presented to the dead ear, if those sounds were detected, it must have been that the sounds had crossed over and been detected by the good side. There's no way that those sounds could have been detected by the bad side. So the difference in pure tone thresholds between the two ears gives you an indication of the interaural asymmetry. So they did that both for the, as I say, both with the supraaural and with the insert headphones. And here's what they found. They found that although there was some approximate differences according to frequency, so we have frequency across the x-axis and then the interaural attenuation in dB on the y-axis, so this is the difference between the good ear and the bad ear. And what I'm showing on here is not the mean, but the minimum interaural attenuation values for that group. And there was some variation across frequency, but broadly speaking, the minimum interaural attenuation values for the supraaural headphones were somewhere in the range of mid-40 dBs, maybe around 45 dBs, whereas with the insert headphone with a smaller surface area in contact with the head, then the interaural attenuation was somewhat higher. So in the UK, what we do is for the supraaural headphones, we take a minimum value of 40 dB just to account for any small frequency differences, and a minimum value of 55 dB for the insert headphones. And if there's any difference between the ears here in pure tone audiometry, then we evoke masking there. In some areas around the world, there might be slightly different rules of masking according to frequency. So for instance, if we look at 4 kilohertz, then there's no need to mask until sounds might be interaural asymmetry of 70 dB. So in the UK we probably mask a little bit too often, but on the flip side it simplifies matters in that we only have one masking rule to remember rather than several according to the different frequencies. So those are where the minimum interaural attenuation values come from, and if you're interested you can have a look in more detail in the British Society of Audiology recommended procedures. Now I'm just going to go through an example now. We're still on pure tone audiometry. I appreciate this is a long-winded introduction, but I think it is important of exactly what happens with using these interaural asymmetry attenuation values in practice. So what I'm showing on here is just a sample audiogram. So I'll just draw your attention to the top left corner, and this audiogram, as you can see, was measured with a supraaural headphones, and it's AC only, so we're interested in whether there's a difference between the ears of 40 dB or more before masking might be required. And in the lower frequencies, so 250, 500, 1 kilohertz here, on the right ear and on the left ear, there's a difference of less than 40, and so there's no risk when we presented sounds to the right ear here of the left ear having picked up those sounds, and so no need to mask. But when we get to 2 kilohertz, we can see that there is a risk, in fact. So the threshold at 2 kilohertz was 50 on the right, but it was only 10 on the left. So it's possible that the threshold as we record it on the right here was actually a shadow of the left. So we decide to mask. Now, as we can see from the schematic up here on the right, although there was a risk of masking according to our minimum interaural attenuation values, in this particular individual, unbeknownst to us, that risk was unfounded, in that, as you can see, the sound waves are not propagating over to the non-test ear. They're not being picked up by the non-test side. They're only being picked up by the test ear. And so unbeknownst to us, this in fact was a true threshold. So when we present masking sound, nothing will happen to the threshold as we measure it on the right side. And that's illustrated in this schematic here of a masking chart. So we have the apparent threshold on the right here, and then the level of masker. And as we gradually increase the masker on the left ear, it doesn't, because the left ear wasn't picking up the sound, it won't change the threshold, and so we just get a flat line on the masking function here. And so we can say that once we get a flat line of so many points, that it was definitely clearly a true threshold on the right. Now, as you remember, the other possibility is that actually the threshold changes. So here we have the same audiogram, but in this example, as you can see from the sound waves, they are crossing over all the way over to the non-test ear. And so it's possible that in this case it was the threshold as we measured it on the right was in fact a shadow curve of the left. So now when we present the masking sound to the left ear, now the curve as we measure it on the right, the threshold on the right, should change accordingly. And so that's what happens. As we gradually increase the masker level, then the left ear is now no longer able to respond. It's increasingly less able to respond to that sound, that crossheard sound, until such time as it's completely unable to respond. And now the only ear that's left is the test ear, the right ear, and so we end up with a true threshold on the right ear, and in this example it was 70. So we would typically gradually build up the masking level until such time as there was no further change on the masking chart. Now, so that's a relatively long introduction. Now I'm just going to move on to considering some separate considerations for masking the ABR.